CataractCoach.com, resident cataract case number 60 review. So let's see what advice we can offer to this young surgeon in training. So of course, this is an anonymous video from a resident surgeon and trying to get the paracentesis made. We're going to show the video in its entirety, but we'll do it at 3 times normal speed. And again, this is about case number 60 for this resident. So you can see it's a reasonable pupil, probably a 6 millimeter pupil, maybe 6.5. Good draping. I like that all the eyelashes are sequestered along with a lid margin. Probably could use a little more anesthesia in this case. The patient has a lot of eye movement, and so you give a little more systemic anesthesia if you wanted to, but also you could have a retrobulbar block to begin your case, or even now do a subtenons. And so right there, we're just fixing these forceps. Those forceps, capsular rhexis forceps, were bent, so that's me. I'm the attending for this case. And I'm going there and just making those forceps back to normal before we start the case and giving the trypan some time to work. That is common when you're at these county hospitals or charity hospitals or VA hospitals. Sometimes the equipment's not the best, or the same person who processes the orthopedic surgery instruments and tools, they're doing the eye instruments, which are obviously much more delicate, and they may not realize that, and they may end up bending them. So just think, when you're in your own fancy private clinic or private surgery center, what amazing instruments you'll have. There's a good fill of the viscoelastic. I like that. Now, I don't think this is an intumescent cataract. Looks pretty reasonable to me. So we're just touching the anterior lens capsule to see, is it intumescent? Do we need to do a double capsular rhexis on this? We can try, go in through the side port here and start the rhexis. Remember, the AC is highly pressurized at this point. And you can just do a baby rhexis just with the cystotome. Now, at this residence level, I'm just doing that baby rhexis for this doctor. So there's the baby rhexis, and I can see that center nucleus. There's really not much of any intumescent fluid. So now the resident's taking over here and going to make a little bit of a groove. I like that idea. And let's take a look at that incision. And that's a pretty reasonable incision. Again, we're showing this at 3 times normal speed, so the resident did slow down and take the time to do this right. Again, touching the center of that nucleus just to make sure there's no extra fluid or intumescent lens, liquefied cortex behind the nucleus in front of the posterior capsule. Now nicking that capsule there, and at this point you can go ahead and create a normal rhexis. So let's see the technique here. That's pretty good. I like that little bit of a pivot there. So again, getting that and using the second hand to stabilize it. And pretty good, not too much viscoelastic leaking out of the eye. Again, make that rhexis a little bigger. No baby rhexis here. That's a pretty good rhexis. It's probably about a 5 millimeter rhexis plus or minus. I think that'll work. So here's some hydrodissection. And we'll hydrodissect, and the nucleus does rotate. Okay. Now let's see what we got next here. What do we have in terms of the technique, the phaco technique? Here's the phaco tip. I like the idea of taking some time to make sure it's the way you like it. And let's see what we're going to do here. Good focus, and it's also important, make your videos in focus. So groove down the middle. So maybe this will be a divide and conquer. Maybe it'll be a stop and shop. I don't recall at the moment. I was the attending surgeon for this case to help this resident for case number 60 here. And so it looks like a groove down the middle and a crack. Does the crack propagate? Maybe, almost. That's a bit of a crack. That looks pretty good. It's starting to get there. And now we have a good rhexis, so we can really kind of put a little bit extra force there to really separate the 2 halves if we need to. And now let's see what's going to come next. We're going to bring a half out of the bag. Hey, very nice. Nicely done with a nice little chop there. I like it. And taking the pieces down. Eye's doing a pretty good job of staying in primary, not too much movement. Again, you want those Purkinje images, that first Purkinje image, to be right there on the center of the cornea. Here comes the second half, bringing it up. And a nice chop. Hey, very nice. This resident obviously has very good hands and certainly practiced a lot. I personally know this resident has spent a lot of time in the wet lab, really just practicing Tenno nylon suturing. And you may say, well, why is Tenno nylon suturing such a magical thing? It's not, but it teaches you to operate under a microscope and do delicate tasks with your hands. So if you can do the Cataract Coach 10-10-10, that is 10 sutures of Tenno nylon in 10 minutes in the wet lab, you're going to be pretty good in the OR. So now cortex removal, going pretty routinely. Not a whole lot of cortex to remove, which is nice. And you may ask yourself, too, at this stage, with 60 cases done, should you do any capsule polishing or that under surface of the anterior capsular rim? You can, But I don't think anyone will fault you for not doing it at this stage. You're still learning, and that's a delicate procedure. Oh, very nice. Now splitting the handpiece into the transformer handpiece into the bimanual. That looks great. And bringing all those pieces in, that's pretty clean. And now filling up the capsular bag with the cohesive viscoelastic and get that lens loaded up. I do like the residents to load their own lenses. There's a lot to be learned from that. And you can't always rely on the technician there, especially in our facility where you have so many. The one technician may operate on the whole body that week. One day orthopedics, one day ophthalmology, one day general surgery, one day gynecologic surgery. You just never know. So it's better for you just to do it yourself to make sure it's done right. So here comes the lens, a little bit of traction there and delivering it. And you're like, wait a minute, where's the third hand? So this is me, the attending, putting the lens in the capsular bag. And now you can see it's a good-looking rhexis, probably around a 5 millimeter rhexis, maybe ever so slightly smaller, maybe 4.8. Pretty good. Here's a good point where you want to try practice polishing that anterior capsular rim using the IA probe when the IOL is already in the bag to go ahead then and clean that anterior capsular rim undersurface. And a 10-0 nylon, I like it. I agree with this. If you've done 60 cases, you need to practice suturing. So 10-0 nylon is good for the patient. It's good for you. You can place that suture. Let's see the technique. Looks pretty good. AC did not deform or deflate. Great. Good job.